All right, anion gaps. So anion gaps are counting of ions that we can't count, right? So you can't count all of the ions, unfortunately, right? There are positive ions and there are negative ions in the body, and you can actually measure that difference. That's called the strong ion difference, right? The difference between positive and negative ions. It should be about negative 40 points, or milliequivalents or millivolts or whatever they measured in, but we have a certain gap of ions in our body, right? So we look at the most common or the most prevalent ions, right? That being sodium, bicarb, and chloride, right? Chloride and bicarb being negatively charged, sodium being positively charged, right? Those are the most prevalent ions. There are other ones, right? There are other cations with T with a, be positive. We got sodium, potassium, calcium, mag, zinc. Hydrogen ions is pretty significant, right? But we also have negative anions, right? We have chloride, we have bicarb, we have phosphate, we got sulfates, we got other little negatively charged stuff out there. Even glucose has negative, positive little situation on it as well, right? But if you add up all of them, that's going to be a headache for one. But also potassium, what's the highest potassium you ever saw? 9-ish, right? That's not going to really change the difference in ions. Same thing with a calcium, 10.5, 12, 13, 14. That's like the highest calcium maybe ever did see, right? Phosphate, 5 points, right? What is it? A mag, 2 points, 2 to 4 points. So those have like really no difference. And yes, you could calculate them all to get a true anion gap, but all you got to really count are the big ones, right? Sodium, what's a good sodium? About 140-ish, right? 135, 145. And bicarb, it's good 25 points, 24 points, right? And a chloride, right? So what's normal chloride? The same temperature as the chlorine pool or chlorine bathtub, right? Not bath. Don't take a chlorine bath. A chlorine jacuzzi, chlorine jacuzzi, right? It's about 104, right? I say 104 because that if you subtract each one of those, that equals about 12, right? So that's an anion gap. That's the gap between the positives and the negatives is 12, right? Positives being 140, negatives being 24 plus 104, 128, right? 128 or 140 minus 128, 12, right? So that's my anion gap. And anion gaps in textbooks are always pictured this way, where it's sodium minus your negative ions. It's like, well, if you just use your math skills, right, you just factor out the negative. Now it's just sodium minus this minus that. That's the easiest. I'm not sure why they didn't take that extra step, right? Usually this is developed by like research people, and I was like, they should be able to figure this out. Anyways, you're subtracting all these things, right? And that's your anion gap. So if you have a buildup of acids, hydrogen ions, which are positive, right? We have a positive minus 2 negatives, and all of a sudden we start building up acids here. Well, that's going to make this from a 0 to 10 or 20 acids or 40 acids, right? So building up acids, unmeasured acids, because there's not many acids we can measure, right? So you're building up all these acids, what's going to happen? What's that number going to do? It's going to go up, right? So I got positive 140 minus bicarb minus chloride plus acids, right? Or minus acids, which are positively charged. That's going to then make my number go up, right? My anion gap goes up when I have the buildup of acids, right? That's called a HAGMA, a high anion gap metabolic acidosis. It's a metabolic acidosis because I'm building up hydrogen ions, right? Well, technically, metabolic acidosis is the utilization of bicarb, right? But the bicarb is being utilized here because of the acid buildup. The bicarb is neutralizing, right? The bicarb is neutralizing it. It was 24. What happens when you neutralize bicarb? Like let's say 10. 10 acids got made. That means let's just say 10 bicarbs got utilized. So it goes from 24 down to what? Let's say 10, right? So I'm utilizing those bicarbs now. So now it's 140 not minus 24. It's 140 minus 10. So we're at 130 minus the normal chloride, 104. So what are we at now? It's early in the morning, it's okay. 26, right? So then we have 26 minus 10, right? So or 26 plus 10 because we're building up the acids. We're adding those acids to the 26 number. 26 plus 10, that's an anion gap of 36. Have you seen an anion gap of 36? Yeah, right? So anion gap's 24, 36, right? I think our lab just like takes a break at 40. So yeah, the scored at 40. You don't worry about it. Or at 60, well, what is it? How bad is it, right? But yeah, anion gap of 36 is bad, right? And anion gap greater than 36 is an anion gap that will kill you, right? So acids that will kill you will cause a high or low anion gap. A high, right? So a high anion gap metabolic acidosis is a buildup of acids that will kill you, right? What are those? So K is ketones, right? So 2 out of 3 of our ketones are acids, right? There's acid, what is it? Acetoacetate, what am I trying to think of? Did I write it there? All right, so we have acetoacetate, you have beta hydroxybutyrate, and you have acetone. That's what I'm thinking of. Acetone gives you fruity breath. Cool, right? Fruity breath, but it's not acidic, right? It's not going to cause problems. So the acetone doesn't cause problems, but the acetoacetic acid, that's an acid, and the beta hydroxybutyric acid, that's an acid. So 2 out of 3 of those ketones that are made from lipid breakdown due to absence of insulin, that's what causes a ketoacidosis, right? So therefore, ketoacidoses cause a rise in unmeasured K.I.L.Us or unmeasured acids, so the anion gap goes up, right? So decay, the anion gap goes up. How do you know decay is resolved? The anion gap goes down, right? Or we say the anion gap closed. It went from 36 down to 12, right? Because it didn't turn off. It didn't go to 0. Because there's still, why is it not 0? Because there's still other stuff in there. There's still other stuff we have not counted yet, right? So that's why it's 12-ish, okay? So K for ketones, and then I for ingestions. So I ingested something that made me acidic. So I ingested something acidic, right? So alcohols get converted into acids, right? So formic acid and other fun acids get made, oxalate or oxalic acid, etc., get made from ingesting alcohols, toxic alcohols, right? So those alcohols are going to add to my acid situation, the hydrogen ions, and that's going to make my anion gap go up or cause a HAGMA, a high anion gap metabolic acidosis, right? Salicylates, acetylsalicylic acid, right, is going to cause a rise in my anion gap, and that's going to cause metabolic acidosis, therefore a HAGMA, a high anion gap metabolic acidosis, right? Go back to ketones, and we'll talk about ketones more. Alcohol itself can cause a starvation state. When you're starving, you're going to start breaking down lipids. You break down lipids, what gets made? Ketones, right? So ketones get made when I break down lipids, and 2 out of 3 of my ketones are acids, right? That's K.I.L. We know L, that's lactic acid. When does lactic acid get made? Anytime there's what? Infection. When infection it will disrupt mitochondria and cause lactic acid to be produced, yes. But also lactic acid gets made when the cells don't get oxygen or get blood pressure, which has oxygen in it, right? So anytime there's poor perfusion, I got cardiogenic shock, I got poor cardiac output. Anytime I have a vasodilation from sepsis or infection, that will also cause a situation where I have a buildup of lactic acid, and that's going to build up my acids over here, and that's going to cause a what? A HAGMA, right? Why is it HAGMA? The bicarb is going down because I'm utilizing the bicarb to neutralize all these acids I cannot measure, right? All the acids are in this anion gap, right? They're rising. We don't know what they are. We know it's either toxic alcohols, it could be ketones, it could be lactic acid, and it's our job to get tests to figure out what is it, right? So oftentimes someone has a HAGMA, it's like, well, shoot, let's get a lactic acid. Maybe that's the reason why they're going up. Let's get a ketone, right? So let's get a ketone level, and that could tell you, oh, that's the reason why, right? And you can get an aspirin level as well, right? And the last thing we get is a kidney function, right? So when your kidneys are not working, what happens? The BUN goes up, right? Does BUN cause acidosis? No, but BUN went up because of acute kidney injury or chronic kidney disease. And yes, that causes acidosis, as we pointed out in our AKI-CKD discussion, right? So you're not getting rid of acids, you're not getting rid of phosphate, you're building up potassium, which also raises your acid situation. So, uremia or, high K. So high K will also cause a acidosis and cause a HAGMA or a NAGMA.
High K would cause
A HAGMA, right? A high anion gap metabolic acidosis. So that is HAGMAs, right? It's because of a buildup of things that will kill you. Okay, and then what about NAGMAs? So can you have a metabolic acidosis without an elevation anion gap? Yes, right? Why does that happen? How does that happen? So it's an important reason because we have not a gain of acids. So it's not a situation where the acids are going up, right? We're not building up ketones, lactate, aspirin, toxic alcohols. What's going on is we lost bicarb, right? It's not because we lost bicarb because acids were building up. So if you take 140 and we lost bicarb because we had diarrhea, right? Because your pancreas secretes bicarb and you poop all the bicarb before your body can reabsorb it, you've lost bicarb. Our acid-base imbalance has now favored acids, right? So we are not 24 anymore, we are 15. So 140 minus 15 is 125, right? And then if we subtract over chlorides, we would then be at what? 125 minus 104 would be like at 20, but shoot, chloride actually goes up in diarrhea. Why? So your body, just like in Star Wars, has midichlorians, right? It just has a way to keep yourself balanced with the force, right? Again, that's called the strong ion difference. You always have an electrochemical neutrality about you. It surrounds all living things. It's within us, right? It's something that makes sure that we always have a electrical chemical neutrality so things can move from high to low or low to high, concentration with protein channels and so forth, right? And then in the brain, on the cells, in our nephrons, etc., right? So we have to maintain that at all times. If we lose bicarb, we lose negative ions, what has to happen? We have to take chloride from the cells and put it back in the bloodstream. So if the bicarb gets lost, the chloride is going to start going, is going to start correcting. Okay, so chloride goes up, right? Because we lost bicarb. We have to maintain that negative balance, or that negative ion balance at least, right? We have to restore the electrochemical neutrality. Okay, so we lost bicarb, so then the chloride went up because we lost bicarb, right? So bicarb went from 24 to 15. The chloride went from 104 to 114, right? Or even higher. In this situation, 120. So we get a nice low number of 5, right? Do we have metabolic acidosis? Yes, because you've lost bicarb, right? You lose bicarb, you have more hydrogen ions at baseline or more. You have a pH that's going to get lower at baseline, not because we gained acids, but because we lost bicarb, right? So the easiest explanation is diarrhea, right? That makes sense. I lost bicarb. The ion got lost, right? So that's the reason why I have a metabolic acidosis, because the bicarb is low now, right? It's not 25, it's 15 or it's 10, right? And the chloride went up to balance electrochemical neutrality, or to maintain this strong ion difference, or to maintain our midichlorian levels, right? So your body always wants to maintain this strong ion difference, and it will do that. If you lose bicarb, chloride will move from the cells to maintain that charge, right? And what if you gain bicarb? Well, then chloride will move into the cells, right? Will that cause acidosis? No, it's just like a little parenthetical, right? So if we gain a whole bunch of bicarb, so take a whole bunch of bicarb in, your chloride will go, well, shoot, bye, right? It's going to then get put into cells, and then you're going to be metabolic alkalosis. Okay, gain of intravascular chloride. So if you introduce chloride into someone's serum, what's going to happen? Bicarb's like, oh, I guess you don't like me anymore. All right, it's going to go into the cells, right, until the chloride goes down. Who would give chloride to a patient? Someone that gave sodium chloride, right? So when you give sodium chloride to a patient, normal saline, all that chloride goes into the serum, and now all the bicarb has to now leave the serum because you have to maintain electrochemical neutrality or strong ion difference, and now you developed a metabolic acidosis, or a NAGMA, a non-anion gap metabolic acidosis, right? So sodium chloride administration is a key reason to cause a hyperchloremic metabolic acidosis, right? What if you gain sodium, right? If you gain a whole bunch of sodium, what's going to happen? Well, you got to maintain electrochemical neutrality, right? You just gain a whole bunch of positive ions. What's going to happen? So the potassium will move into the cells, right? So when we talk about hyponatremia, for instance, right, and you give sodium to someone, that's going to cause someone to get hypokalemic, and vice versa, right? Someone's hypokalemic, I give potassium to someone, well, now the sodium has to then go into the cells, right? So it's actually dangerous when someone has hyponatremia, really low sodium, like, oh shoot, sodium is low, and someone's like, oh, the potassium is low too. And it's like, okay, give potassium over there. That's not going to affect the sodium, right? No, it's going to make your sodium go down when you give potassium to someone who's hypokalemic and hyponatremic. So we'll talk about more detail when we talk about our hyponatremia, which is all fun sodium stuff. Okay, so you raise sodium levels, that's going to lower my potassium levels, right? It's actually one of the older treatments for hyperkalemia was to give 3% saline. That was a fix for someone with hyperkalemia. Okay, so we have to maintain a strong force within all our patients. And then also up the corner here, you can see NAGMA. What's going on? Bicarb is low because we're losing it, right? Anion gap is not bigger, right? It's actually maybe even the same or less, right? It's not bigger because we're not building up acids. In HAGMA, we're building up acids. In NAGMA, we're not building up acids, but we are losing bicarb, or it's being pushed away into the cells because we gain chloride, for instance. All right, so a little bit more detail on HAGMAs. So HAGMAs are high anion gap metabolic acidoses. Again, anion gap is your sodium minus your bicarb minus your chloride plus an acid. So an acid is built up for some reason, right? And what acids are those? Those are acids that will kill you, right? As you talk about the keto acids, 2 out of 3 are acids, right? So acetoacetate or acetoacetic acid, beta hydroxybutyrate or beta hydroxybutyric acid, right? These are acids, right? The other one, acetone, makes you have fruity breath, right? So it's like doublemint gum, right? Acetone will make you have fruity breath, but it won't contribute to an acidosis or anything, right? How else can you get acids? So lipid breakdown of any sort causes ketosis, right? Causes ketone generation. So because our brain works on ketones, right? The whole reason why we have ketosis is because of our silly brain, right? So if we didn't, if we were in starvation and we didn't, and our brain could work off of proteins or work off other chemicals for nutrients, then we would not have this problem, but we do. Okay, so we have to make ketones when someone is starving. So that's another reason why we might have ketoacidosis. Someone's starving. Do alcoholics have great diets? Are they like eating Thanksgiving dinners every day? No. So alcoholic ketoacidosis is another reason why someone might go into produce keto acids. Okay, ingestions. We'll talk a lot more about alcohols in the next coming slide, right? But alcohols themselves get converted into all kinds of different acids. That's what it will point out coming up, right? Methanol makes like formic acid. Ethylene glycol makes oxalic acid. Salicylates, such as aspirin ingestion, right? That's going to cause also a rise in acid generation. And when we talk about our alcohols, and we'll talk about something not called an anion gap, but a osmolar gap. So it'll tell us if someone has ingested alcohols or not, right? We can't just run a test like, oh, let's check the ethylene glycol level, or let's check the formic acid level. It's not a thing, right? So we have to investigate, ask them, what'd you drink? Or we do what's called an osmolar gap, which we'll point out on an oncoming slide. We talked about lactic acid, right? So they have a lack of perfusion for some reason, because lack of perfusion means lack of O2 delivery. Do they have cardiogenic shock, or are they extremely hypoxic with ARDS? Do they have a dysfunctional tissue for some reason? They have compartment syndrome, right? All these different lactic acids can develop when we have a lack of oxygen, right, to tissues. So we have just compartment syndrome could be a reason why someone's acid level would build up, right? So we had a patient that had lack of perfusion to both legs, and they're on 2 pressors, but then all of a sudden lactic acid went from 8 to 32. It's like, well, that's because they probably had an acute occlusion a full occlusion of their legs now. Okay, so dysfunctional tissues like sepsis will cause dysfunctional mitochondria. Therefore, we have to convert to lactic acid production for energy, or we have buildup of lactic acid, like with metformin. Or it will cause it inhibits the breakdown of glycogen in the liver, and therefore we have if we're not breaking down glycogen, we're going to have a lot of glycolysis that's going to happen, and therefore they can build up a lot of lactic acid with metformin buildup. And when does metformin build up? In renal failure and kidney insufficiency. That's why metformin is contraindicated in kidney insufficiency or renal failure or post-contrast, right? What else? So PRIS, or Propofol-Related Infusion Syndrome. So this is when with a lot of propofol infusion, it can start causing a metabolic acidosis because of the generation of lactic acid. It also inhibits mitochondrial function as well. Another reason we might have a toxin that's causing our cells to produce lactic acid. Okay, and then uremic acidosis. So uremic acidosis is due to poor kidney function, right? So kidney function is poor. You build up acids, including hyperkalemia as well. So hyperkalemia or AKI or CKD, all these things can eventually lead to acidosis, which will then cause a buildup of acids, which is a definition of HAGMA, or high anion gap metabolic acidosis, right? And just a note, when you have someone with chronic kidney disease or AKI, their bicarb does not usually fall below 18 to 12, right? Usually it's not. It'll stop, like at 15, 14 or so. When someone with AKI also has bicarb that's like 4, they probably have lactic acid also brewing, or they have a ketoacidosis brewing as well. You have some concomitant acidosis, right? Because you can have more than one of these at the same time, right? Ketoacidosis, that we'll kind of find out in diabetes, is caused by infection, right? So if you have an infection, that can lead to sepsis, like lactic acidosis, which also leads to ketoacidosis. Now you have 2 acidoses on top of each other, and that can lead to poor kidney function. So that's 3 acids that will kill you. So what's the treatment? Underlying cause, that's an easy answer, right? That's how we're going to fix this, right? Ketoacidosis, what do? I got to stop the lipid breakdown. How do I stop it? Discontinue propofol, but also discontinue lipid breakdown with insulin. So insulin is the off switch for ketosis, right? So insulin is going to stop lipid breakdown, right? What insulin does is stores lipids, right? It doesn't break them down. Okay, so dialysis, if you have AE-IOUs, we talked about a lot with CKD, AKI, anytime you have one of those letters, it's a problem. When you have 2 of those letters, you need dialysis, right? And one of these letters, you absolutely need dialysis. Which letter was that? So that one's up. There's no medical therapy invented so far that causes a reduction of this vowel, so we have to get dialysis no matter what when they build up uremia, right? But if they have an acidosis and an electrolyte AE, right, situation, then we have to do dialysis. If they just have electrolyte situation, maybe we can fix it with hyperkalemia therapy, right? Or they fix the acidosis with a bicarb infusion, right? Not a bicarb drip, or not a bicarb push, please. Okay, and then bicarb infusion, there it is, right? Not push, right? And of course, they have to wash off the fluid balance because they already might have an AKI, and that can put them at risk for fluid overload, and fluid overload has bad outcomes, as we'll come to find out. All right, and then hyperventilation. That's going to fix, if they're ventilated, we can ventilate them quicker to blow off more CO2 to make room for the acidosis, to blow off, as a compensatory mechanism. All right, so we've got uremic acidosis, the U, ketoacidosis, lactic acidosis. There's many reasons for it. And then we have ingestions that can cause a buildup of acids. So one of those ingestions could be alcohols. And believe it or not, there's more than one alcohol out there. There's our favorite alcohol, ETOH, ethylene alcohol. All right, ETOH is very common to be ingested, and that can lead to starvation situations and lead to acidosis. But so it can lead to acidosis in and of itself. And it's see, as you can see, ethanol is being converted by this enzyme right here. Alcohol dehydrogenase. It dehydrogenases alcohols. It takes the hydrogen off, or sorry, it adds to it, and that then creates a acid, right? So we get acid out of that situation. So that's great if it's to neutralize acids, if your kidneys work, or if or acutely, or like small amounts, I should say. But when you're ingesting huge amounts of these, you're going to start forming all kinds of other acids, right? So we have to be alert to that. So what are symptoms of alcohol toxicity? They have acidosis, they have HAGMA, that's why we're talking about this, and also they have high osmolarity. I think we've talked about this, touched on it a couple times, we'll touch on it a lot more today, but how do you calculate a serum osmo? A serum osm, what is serum osmolarity? What's a normal value? 280 to 300, right? It could be 285 if you're like, push up your glasses. 285 actually, right? But yeah, 280, 300, that is a normal serum osm, right? So how do we calculate that? I mean, we can calculate it, right? We can estimate what it is. Usually 2 times your sodium is going to get you there. Normal sodium, 140. 140 times 2, 280. Almost halfway there, right? And then what else is osmotically active in the serum? Well, we talked about BUN with ADH, right? ADH in pre-renal failure absorbs so much BUN so that water follows, right? Because it's super osmotically active. If you take someone's BUN and you divide it by 2.8, that's going to add to someone's osmolarity, right? So if someone's BUN is 28, that's going to add 10 points, right? It's 20 divided by 2.8, 10, right? So it's normal BUN being 20, so about 8-ish, right? So we already got 280 plus 8-ish, right? So we're at 288. And then glucose. What's normal glucose? Less than 180, right? So if it is 180, 180 divided by 1.8 is the formula, so that's 10 points, right? So that's going to add 10 points to it. So we got 10 plus 10 plus 280, 300. 280, 300 is a normal serum osm. That's a calculated serum osmolarity, right? But what else is osmotically active? Alcohols, right? Ethanol, methanol, we have ethylene glycol, propylene glycol, isopropyl alcohol. These are osmotically active, right? They also pull water wherever they are introduced, right? In the serum, for instance. So we can calculate what the serum osmolarity is from the numbers, from sodium, glucose, and BUN, and say, hey, that's what their serum osmolarity should be. What if I actually measure the serum osmolarity? I measure the serum osmolarity and I get 320 or 340. That means something osmotically active is in there. We can't measure it, but it's there. Just like with anion gaps, there's an acid there, but we can't measure it. Here, there's an alcohol there, which is osmotically active, but we cannot measure it. So that's called the osmolar gap, right? So we get our measured one, 340, minus our calculated one, based on our sodium, glucose, and BUN, let's say 300. That means I got a 40-point osmolar gap, right? So osmolar gap can tell you that you have a toxic alcohol ingestion, right? So there's some other symptoms that might be present. Obviously, we have a HAGMA, so we got a metabolic acidosis and lactic negative. What else is negative? What else would not be there that would kill you? They don't have. Okay, you can also think of K.I.L.U, right? They don't have hyperkalemia. They don't have ketoacidosis. They don't have L-lactic acidosis. They don't have kidney failure. But now we're talking about ingestions, right? So we're like, what did they ingest, right? Did you ingest aspirin? Well, I can check an aspirin level, right? Did you ingest ethylene glycol? I can't test ethylene glycol, but I can test to see if there's something there. And you can then investigate, and then the family goes home and say, oh yeah, there's an empty bottle of antifreeze here, right? So that's the reason why they have a osmolar gap. Okay, so osmolar gap is going to be evident in toxic alcohol ingestions, right? So seizures can happen with severe acidosis, right? They're going to have SNS symptoms because they're super acidotic, right? Certain alcohols cause vision changes. So these two over here, methanol, which is found in Windex and paint remover, causes visual changes, and isopropyl alcohol, right? We use to get the nail polish off our fingers, right? That can, and also what else we use isopropyl alcohol for? To clean things sometimes, right? So that will then cause a visual changes. So they come in complaining of vision changes. That, yeah, it could be one of these two alcohols. Okay. The unique thing about isopropyl alcohol, it has no reactivity. It does not get broken down. It gets converted to our friend acetone, which causes what? Causes fruity breath, right? Cool. You got fruity breath, and they look like super drunk, right? So not sobering up. Like isopropyl alcohol is like E2H on steroids. They're extremely drunk, right? And they don't have acidosis. They don't have HAGMA. It's the only one that doesn't have metabolic acidosis. But there is an osmolar gap, right? And they got visual changes. They're starting to hallucinate, seeing stuff. That's isopropyl alcohol toxicity. Okay. And then ethylene glycol. We talked about ethylene glycol, and the reason for the FDA was ethylene glycol. And cats, they like to go under the engines because they're warm after everybody parks at night in the winter, and they like to eat or drink the antifreeze because it's sweet, and they start getting kidney stones, and it causes your cats to go into kidney failure, right? So also causes kids to go into kidney failure in the 1930s. That's why we had FDA rules now. And also someone comes in with acute kidney injury and kidney stones and painful urination, hematuria, maybe they might have ingested ethylene glycol. Okay. And then what else? We got hypocalcemia also results from ethylene glycol because it's binding calcium in the urine. It makes oxalate stones specifically, and that will then crystallize, causing stones, but it also causes a renal failure to develop. All right, so how do you fix this? So the way to fix it is to give, yes, fomepizole, but to call poison control first. They're saying, I think this person ingested something weird, and they're going to kind of walk you through it. Are there any visual changes? Are there any stone changes? Are there any, what are the labs? Do they have a HAGMA, right? Do they have an osmolar gap, for instance? Right, so poison control is going to be a key player in this. And then fomepizole. So fomepizole is our treatment right here, and it stops this process, because this process that normally digest alcohols in normal amounts. Now there should be normal amounts of hand sanitizer, right? But it's not, it's like, oh, hand sanitizer ingestion. What's the normal amount to drink? None. But if you do drink hand sanitizer, what will happen? Well, that's a bad example because it won't cause metabolic acidosis. But we are still stopping this breakdown of, well, I guess it's still true, but it won't cause metabolic acidosis. We're stopping this breakdown of these acids that will develop if you were to let the body continue to break down those acids naturally. So we give fomepizole, which is going to be the treatment for toxic alcohol ingestion. All right, what else? So another option is ethanol. You can actually give someone straight up alcohol. If someone overdoses on ethylene glycol or someone overdoses on hand sanitizers, here, drink some actual liquor. And that will actually stop the process as well. So it will actually take up the enzymes and it has preference, right? It has like VIP seating for that alcohol, for that alcohol dehydrogenase. All right, so osmolar gaps. So those are measured with when we have toxic alcohol ingestions, and we can look at other things to tell us if other clues, other histories. Do they have ketones developing, right? E2H causes ketones, isopropyl alcohol causes ketones, so running ketone levels, running our chemistry, we'll look at our serum osm, can tell us information about the anion gap and the osmolar gap. And usually anion gap will go up, and our osmolar gap will go down. In some alcohols, it happens really quickly, but definitely the beginning is the key piece to get these tests done, because when they first ingest it, it's going to be osmotically active. It's not going to be broken down as quick. When it gets broken down, that's when you're going to start having the anion gap goes up because we're creating all these acids, right? But at the beginning, we have all these osmotically active substances that are causing an osmolar gap. Okay, so comparing those could give us good information about a toxic alcohol ingestion.